Hey, good evening, and welcome to your favorite medical show, Ask Dr. Saw. Joining, he's still in England.
Good evening, Akash, and the viewers.
Wonderful, Dr. Saw. I just want to say to you, Dr. Saw, that the reviews and the comments that we're getting from this show has been phenomenal. It's been amazing, and people are really. Some people are saying to me that this type of information is the type of information they would always want to hear. Sometimes it's difficult for them to have access to this information. They like the way you're breaking it down to them also. So, I just want to say from all of us here to thank you so much for what you're doing on this show, Dr. Saw.
You're welcome, and I try my best to make it as simple as possible.
Right. And viewers, just to let you know that when you can send in your question to us while we have this conversation on our subject tonight, you can send in your question to us. And next week, myself and Dr. Saw are going to address your questions. Of course, I'm going to be asking, and he's going to be answering those questions for you. And we have a number of questions from last week that came in. And after this first segment, we're going to go straight into that. Time runs out on us, so we've got to get into it. So, Dr. Saw, this evening, we are talking about a subject that is sometimes taboo. It's constipation. But I believe that, every one of us, I believe, must have had some run-in with that particular issue, but constipation. So, most of us know what constipation is, but is there a specific criteria that defines what constipation is, though?
Yes, of course. For medical purposes, of course, we have to have a criteria. However, as you know, you said most of us would say we've been constipated at some point or the other for various reasons, and that's a one-off. So there is what we call a subjective and an objective way of describing constipation. So subjectively, if you normally go to toilet every day and you haven't gone for a couple of days, you will define that as constipation. Mm-hmm. But objectively, that is not considered chronic constipation. So we're looking at more, not a one-off constipation, but this is someone who's got constipation for a period of time. And as you know, what is constipation? Constipation is infrequent or difficulty in defecation or passage of stool. So you're having some difficulty and it is less frequent. Mm-hmm. Now, of course, frequency, we then would objectively define what is considered normal. So there is something called the Rome 4 criteria. And Rome 4 criteria in medically, that's what we use to say somebody is chronically constipated. And it says if you have two or more of these things that I will tell you about mm-hmm. in the preceding 3 months, you would say you're constipated. And what are the things we're talking about? So if you have two out of these, two or more, and it should be in the preceding 3 months, 3 months prior, you haven't this. So you have less than 3 stool per week. So less than 3 stool per mm-hmm. week. If you have 25% of the time, you have to strain. Mm-hmm. If you feel that you are a sensation of you're not fully empty, mm-hmm. 25% of the time. If you feel that you are obstructed, 25% of the time. And if you feel that you have to use some sort of maneuver, where lots of people do digital evacuation, so if you have to do that 25% of the time and more, and you have two of those, so we look at sensation of incomplete emptying, maneuvering, digital maneuvering, a sense of something is obstructed, hard or lumpy stool, and less than 3 per week. If you have those, you have two or more of those, you can say, according to the definition, you can say you're constipated.
Okay.
So that is what we use, in the medical terms to say, right, this person is constipated. But of course, if you, and of course, if you used to go, your body tells you how you are. Some of us are trained differently. Mm-hmm. And I've got patients who say, I go 2 times a week, and I've been doing that for years and years, and it doesn't bother me. But it is, as I say, it is also associated with symptoms. So if you're uncomfortable, if you're going twice a week and fine, that's how you are, and you're not having symptoms. It is not ideal because I will tell you some of the things that long-standing constipation can give rise to other problems. And of course, we don't want someone to go twice a week. We want you to evacuate your bowel more often than that, at least 3 or more times a week.
Brilliant.
So, yes, that's your criteria and that's your definition.
Brilliant. Before I ask you, I want to ask you next thing, what are some of the major causes for constipation? But you also mentioned just now digital evacuation. Just touch on that a little bit for me, please. What is the digital?
So, of course, if you feel that you're blocked, you're obstructed, and you feel that, okay, the stool is coming out, but there is something blocking it, and you just feel it right down at the end of your anus, it is there. Lots of patients will come and tell me, Doc, I have to go in the bathroom, I have to use my finger, and so they use their finger, put it up their anus, and try to pull the stool out.
Oh.
So you initiate, so you're creating that initiation because sometimes the stool is so hard, it is blocking the entrance. So once you start to digitally pull it out, you will see it probably will flow. I mean, yes, and if you do that 25% of the time at least, and you have less than 3 per week, you can say you're constipated, and that will suit the definition.
Brilliant. I wanted to, because I didn't know what that is.
Yeah, it is. I mean, it's something that I suppose it is so personal.
Yes.
And so private that you would not hear that. No one will come and tell you that this is what I'm doing.
Right.
But it is something that is very common. I've seen lots of patients over the years who come and say, Doc, if I don't do that, I don't feel emptied. I don't feel that I have opened my bowel properly, and it's an issue.
Right.
So, yeah, no, it's something. I know it sounds a bit.
And I guess that's what that is why, when at the beginning of the show, at this particular segment, I said that some of the, this thing is taboo. A lot of people don't want to talk about it. But what causes constipation, Doc?
Well, various reasons. I mean, constipation is very, there's no one cause. And lots of time, yes, we try to define and look at different causes, but there is always an overlap. There are a combination of things that can cause it. So just for simplicity, I like to, do things in a very logical way for us to understand it. So we have something called, we can divide constipation when we look at the causes. Primary constipation, that is, there is no identifiable medical cause or underlying medical cause. We don't know why you're constipated. So we call that primary constipation. Or sometimes we call it functional constipation. And I explained to you the analogy sometimes that, you look at the pair of glasses and it looks okay, nothing is wrong with it, but I look through it and I can't see. So it is not functioning, but physically it's good.
Yeah.
So likewise, in primary constipation, it is sometimes defined as functional constipation. Idiopathic, as in no known cause. Functional, as in, physically there is nothing. And we call that primary. So there is no physical or underlying medical condition. And then you have secondary causes. Secondary causes meaning there is something else that is causing the constipation. So when we look, so we can then define, so we were looking more, when we look at the causes, we say, fine, you either have primary or secondary. Secondary causes, what are some of the other causes? So there's an underlying medical cause. You can have, let us look at the colon itself or the GI tract. So the colon and the anus, so your colon store the stool and then it is evacuated from the anus. So if you have a problem there, as this is secondary causes now, so let's say for instance you have pain in the anus. Pain in the anus like piles, an ulcer, it's called fissure. You may hold your stool in. You don't want to go because every time you go to the toilet, you're in pains. So you're training your body not to go. So that can cause constipation. As a matter of fact, that's a very common cause of constipation. If you have a tumor or something blocking the flow of the stool, so in your colon, if you have cancer of the colon, a mass, it doesn't have to be cancer, it could be any other mass. If you have a stricture, a blockage, the colon has got a normal size. If for whatever reason the size is smaller and you're having a blockage, so those are GI causes, the colon and the anal causes. Now, besides that, another secondary cause could be endocrine causes. So endocrine meaning we talked before about thyroid disorder.
Right.
So I think I had mentioned when you have low thyroid, your body is sluggish.
Yes.
Because thyroid is the metabolic hormone that allows you to metabolize and it gives you energy. So if your thyroid is low, your body slows down, so that can give rise to constipation. If you have other endocrine problem where there's a gland behind the thyroid called parathyroid that can produce excess hormones, parathyroid hormone, and you have raised level of calcium. So whatever reason you have high calcium in your body, that can also cause constipation. Diabetes. Diabetes affects the nerve. Diabetes can cause constipation because the bowel has got a nervous system of its own.
Right.
So it is defined, we have established that. In the walls of the bowel, it has got nerve cells. And that causes stimulation.
Right.
When you have activation of that, the bowel contracts and it causes peristaltic movement. So, endocrine. Let's see. There are other causes like what we call connective tissue disease. So there is a condition called scleroderma. Patients who have that type of arthritic type of condition. So all these joints and skin disorder, you can get associated constipation with it. Big cause, medication. Lots of medication can cause constipation. People who take iron supplements,
right.
They will come and say that they are constipated. People who take antidepressants, they can cause constipation. Patients who take psychiatric drugs, it can cause constipation. The bowel movement is controlled by the nervous system as well, cholinergic nerve we call it. So there are some tablets that you use, they are called anticholinergic. So patients who have got prostate problem or so, we can give them drugs to relax the muscles of the prostate, and these drugs can cause constipation. So that's your summary, and also not forgetting psychological causes.
Right.
So if you are, for instance, you're in a different environment, and
absolutely.
you go on holiday, sometimes people will come and say, Doc, I've been on holiday,
yes,
and I haven't opened my bowel for a week.
Yeah.
So that would be your acute constipation. So there are various causes, and we tend to look, take a history, understand what else is going on, because it's not just only the bowel causes. We've talked about bowel causes. And if we can't identify any underlying cause, we will say this is functional or primary constipation.
Right. Doc, look, it may seem as if it's obvious to say what are the signs and symptoms of constipation. It may seem very obvious. But from a medical standpoint, can you then tell us, Dr. Saw, what are the signs and symptoms that we should look out for?
Of course. You said commonly, you all know. You can't pass stool.
That's right,
I can't pass stool and I'm uncomfortable. So you would have to have some degree of discomfort.
Right.
And what is the discomfort? You'll have abdominal pain. So you have abdominal pain. You may feel a sense of bloating. You may feel a nausea, sickness. You may even vomit. Some patients with long-standing constipation, they say, Doc, I'm always bloated. I feel that there is gas coming up. I'm belching a lot. I feel sick. I feel nauseous. And constipation, as I said, even in reflux disease, constipation can give rise to acid reflux. You have more gas building up in the stomach, and you have acid reflux symptoms. So, you have tummy pain, bloating, acid reflux. Constipation can cause back pain. You can have back pain as a result of constipation. You can have urinary retention. You can't pass urine because of your constipation. Associated with constipation is a cause as well. Patients usually come and say, I've got anal pain. So if you've got hemorrhoids, so whenever you have you're looking for causes as well, but these patients, these are the symptoms would allude you that, hey, there is something something going on. I've got constipation and I've got anal pain. So if you have hemorrhoids, if you have an ulcer, which is like something we call a fissure of the anus, they can also cause constipation. And yes, the symptoms you'll strain, so straining can do that. Now, something that is probably not, we don't see that commonly. However, in my part of the world, I see it very commonly. If a patient were to, usually I see patients in residential home or nursing home, and we're talking, it's only because of life expectancy, I say we don't see that commonly in Guyana. But life expectancy in the UK, for instance, is over 80-something years, 83 plus years life expectancy. So we have a big chunk of elderly population, and a common cause of confusion, acute confusion, is constipation. So ever so often I get called in to see patients in residential care, and patients with poor mobility, and suddenly they get confused. What do we look for? In acute confusion, you want to know, is there any signs of infection? So if you have urinary tract infection or infection, and also constipation is a big cause of confusion. So it is not just, all right, I'm just constipated and I've got some tummy pain. You're delirious. So it's not something as trivial as it may seem. It can be, it can have serious, implications.
I had a case. I had a case. Someone came to Guyana some time back, and they were here in Guyana, and they stayed at a hotel, and for 5 days they could not go to the they could not go. I think I think I had mentioned it to you. I had to actually
of course.
Right. I had to actually call in. I had to actually call an emergency made an emergency call for them to go in, and she ended up at the hospital. Thank God she's okay now.
No, of course.
Yeah. But
I remember that we spoken about that before.
Right, but she, this person was there in the hospital suffering. He really, and I don't know because of the taboo, she doesn't want to call. It's going to be shameful to say that you're constipation. What are some of the red flags that we should look for, though, Dr. Saw? Are there red flags in this whole setup?
No, absolutely. There are red flags and there are complications. So red flag is telling us that, okay, you don't have, this constipation is not something I should just, ignore. This is a constipation that is telling me something else is wrong with me, and I should see the doctor, and I shouldn't just take laxative or say, right, this is normal constipation. So what are the red flags? If you have constipation and you're losing weight, that's a red flag. So we will tell anyone, if you're constipated and you're losing weight, you should see the doctor, because we want, to the back of our mind, we want to make sure it is not cancer. So more or less, we are looking to exclude cancer, because the guidance tell us that anyone who has got, especially over 50, if you've got a change of bowel habit, so if you used to go once a day and then you start going every other day, and you're over 50 years of age, that's a red flag. Change of bowel habit with weight loss or something else will tell us that this is constipation. If you are anemic, if you're constipated and either I look here and you look pale as if you're anemic, or I do a blood test and it shows that you're anemic, that is telling me that you're bleeding and you're constipated. What can cause that? So cancer of the bowel presents like an ulcer. Now you have an ulcer in the bowel, and generally, as you know, cancer starts like an ulcer and it grows and it spreads and it expands. You may bleed slowly that you don't see it. The blood is mixed with this stool, but it is microscopic.
Oh, okay.
So you don't see it in the toilet. And that is why one of the things we do in patients, we send them for a stool test to check to see if there's microscopic blood. It's called a FIT test, or fecal occult blood test. And if that is positive and you're constipated, I will always send you to have a camera. That is to do further testing,
right,
like through cancer. If I feel that there is a mass in your tummy, I can feel if you're constipated, of course, you want to examine that patient. You will feel if there's a mass. If there's a mass, of course. What else? If you've got a family history of cancer, bowel cancer, cancer that is, and you're constipated, that's a red flag for me. I will go on. And if you have rectal bleeding. Now, rectal bleeding without an identifiable anal cause. So if you're constipated and I find that you said, okay, doc, I'm bleeding and I'm constipated, but I have hemorrhoids, I go and examine you, and I see you've got hemorrhoids, I say more than likely this is coming from the hemorrhoids. I can see it. Or you've got an ulcer of the anus, I can see that. However, if you're constipated and there's blood in the stool, in the toilet, and I can't see an anal cause, I want to investigate that further. That's a red flag as well.
Right.
So, I mean, that's your summary of red flags. And then, of course, what are the complications? Can constipation be dangerous?
Right. Yeah. I mean, you did mention some of the investigative methods that you can use there. But I always ask to the extreme if I mean, constipation. I'm sure that it can do some harm because it'll damage tissues and all that. But can constipation be lethal?
Lethal is it going to kill you?
Yeah,
well, yeah, depending on the cause. I mean, yes, if constipation is as a result of cancer,
right,
and you ignore it, of course, because you can have a blockage, a cancer blocking the flow of stool, and of course that can be fatal. So you ignore the constipation and you're losing weight and you start getting blood, and by the time you realize it, it's too late, you've got bowel cancer. That spreads. Bowel cancer is a cancer that is so curable, to be honest. Curable meaning if you've got bowel cancer and you pick it up early, you just treat it, you resect the bowel, you're cured, as in no more cancer.
Wow.
But if you allow cancer to spread to other parts of the body, I mean, then that is, usually terminal, or that will lead to death eventually. So we want to pick up those things early. So it's not just trivial. So complications, yeah. But that's an extreme position, an extreme case, I'm telling you.
But Doc, 1 minute, please. Look, I understand that, but what I'm asking about, look, I know sometimes when you can't make it to the toilet in time, it doesn't have to be constipation. So you cramped up, you can't move, you can't,
Yes.
I'm pain is and sometimes it's not even constipation, just that you can't make it, you not close to a toilet. I can imagine people who are constipated and have to go through this for days. I'm thinking you get cold sweats, you feel like you can't breathe properly, and so I'm thinking, man, that could kill you. I don't know. I could be wrong, but
I suppose pain by itself can give rise to things like, if you are, I always say, there are
threshold low
that we have who are sitting on that equilibrium, where they are just sitting on that thin line where there's an equilibrium there, and when that equilibrium is shifted in a way where it causes an imbalance, it can kill you. And I mean, this is classic of, you have seen patients where they have lots of medical condition and we're just getting them tipping over.
Right.
They just got a flu and they die.
That's right. Yeah, because you got underlying conditions.
That is the point. So what you're describing there is that if you have a patient that they've got so severe pain, and the pain triggers something. The pain can trigger your heart going into an abnormal rhythm.
Yes.
The pain can trigger your blood pressure. Your blood
abnormal breathing too.
High. And abnormal breathing, of course. It trigger a heart attack. So pain by itself can be fatal if you are sitting at that equilibrium. So it is not that none of this thing can be fatal. They can. So you got to look at it in that context. But one of the more serious things in constipation, you have a blockage. So if you have a blockage, it can cause bowel obstruction. So think about it. Your bowel is not opening, so you're not passing stool, you're not passing wind. The bowel is totally blocked.
Right.
Nothing to happen. You get toxins building up. You have gas building up. Your tummy gets distended. You start to vomit because you cannot take anything down. Everything is regurgitating. And that is defined as bowel obstruction. And of course, that can be fatal as well. Now, constipation can also give rise to anal problems. We have blamed constipation on things like you strain and you cause a tear in the anus.
Yeah. So we got Doc, we got about 5 minutes more on 5 minutes more to finish up.
Fine.
Yes.
Just
yeah.
click on that. With anal problems, so the constipation can give rise to a tear in the anus. So we call that anal fissure. Constipation can cause high pressure in the anus and rectum, and there is a condition called diverticulosis. And when it is inflamed, it's called diverticulitis. So, you know, the bowel has got a wall, and the pressure in the bowel is, should be at a certain pressure. If that pressure is elevated and there's a weakness in the wall of the bowel, you have an outpouching. Oh. So, I always make a reference like a balloon.
Right,
you
right.
blow a balloon, and if the wall, part of the wall of the balloon is weak, you'll see a bulge.
That's right.
Or a bicycle tire.
Yeah.
Yeah, you see that little bulge. So that is called diverticulosis. And when that gets inflamed, it's called diverticulitis. And it can present like, appendicitis, it can burst, it can cause an abscess, it can cause... So you can have complications as a result of... complications as a result of constipation, that give you diverticulitis. What else? Pelvic floor. I mean, they've blamed constipation as a cause of weakness in pelvic floor. So in women who usually they can have weak pelvic floor. So when they sneeze, they have urinary incontinence.
Right. Yes.
And so all of that can be linked to constipation. So it's not just, it's something that we should look into and we should manage and treat.
Before I go, we got about 4 minutes more to go. But before I go to ask you about treatment, I want to ask you this one thing more quick, because I heard this when I was a kid. If the walls of the intestine becomes really weak and the stool is very hard, can it burst through there? Can it burst?
It can, yes. So that is happening. That in that diverticulosis condition I explained. So the wall is weakened. It has a bulge. And usually, if the pressure is high, it has a bulge, and you have inflammation, then it can burst.
Right.
So you can have a perforation.
Right.
So you can have colonic perforation as a result of that. So, and then when you have it burst, you can be septic. It could be fatal, because the poo now gets into your...
That's right, in the abdominal cavity, right? Yes.
Correct.
Yeah.
And then also that weakness, when it gets inflamed, it can get attached to the, we call it a fistula. It get attached to the, let's say, the bladder.
Right.
And then you have poo getting into your bladder.
Yes.
Because remember, all the tracts of the body, they're closed up. So from your mouth to your anus, it's a little tract that it doesn't have connection outwards that leaks into anywhere.
All right.
So if there is a little perforation there, it gets into the rest of your body.
All right, so tell us about treatment. Tell us about treatment in a few minutes, Doc.
All right, quickly. So treatment. I always advocate, let us talk about non-pharmacologic means of managing constipation. And the important thing is lifestyle. Let us look at our diet. So diet, fluid, and fiber. Think about the two F's. Fluid and fiber.
Right.
So you want to have enough roughage or fiber in your diet. And what contains fiber? Fruits and vegetables, they are rich in fiber. So you want your diet to be varied in fruits and vegetables. Fluid, you should have adequate fluid. Now, there are things that sometimes we take that cause us to get dehydrated. So overconsumption of coffee, overconsumption of tea, they can act as a diuresis, as a diuretic. So you get dehydrated, it can cause worsening of constipation. Alcohol also can work as a diuresis. It can cause worsening of constipation. And of course, certain food. There are some people with milk products, they can get constipated. So you have to look at your diet, increase your fiber intake, look at certain food that is triggering your constipation, try to avoid them. So that's the hallmark of constipation, lifestyle. Now, what you're going to do if that doesn't work? So you're drinking enough liquid, you're taking fiber. The doctor can also prescribe fiber, because the medical evidence tells us if we advise patients to do fiber and fluid, that alone would not cut it. Most of the time, they would want some prescription for something that we prescribe. And we sometimes prescribe fiber. So fiber, you have different types of fiber. So fiber gel has got fiber, psyllium and methyl cellulose and all those things are fiber-based product that we would prescribe, and you have that. Now, quickly, if that doesn't work, so that's your best case scenario. Fiber, fluid, and lifestyle changes. Exercise. Exercise is known to stimulate the bowel. So we want to exercise. Now, go on to pharmacologic laxatives. So we're using laxatives now. Now, laxative, a lot of people feel that laxative, you just go and buy any laxative. No. So some laxative can be harmful long term, and some laxative, they're safe. So fiber is a type of laxative, so we would encourage fiber laxative. Laxative is divided into the way they work in the bowel. They have different, we call them stimulant laxative, osmotic laxative, stool softener laxative. So depending on, so if I want, like senna, for instance, is a stimulant laxative. We don't want to use too much of stimulant. The stimulant laxative is a little bit, not recommended.
Right.
Whereas fiber laxative is recommended. We also have stool softener. So stool softener laxative, what it does, it breaks the tension, the surface tension of the stool. So you have more water getting into the stool, and it softens the stool. So we call that stool softener. A common one is called Docosate. I don't know if you heard of that.
But there are suppositories that does the same thing too, right?
Suppositories. Well, suppositories would be more like, what it does, it attracts water into the bowel, and it softens the stool. Things like lactulose, they are osmotic laxative. Now, there are some newer types. We got
1 minute to go, all right?
All right. Right. The newer type of laxatives are tablets. There are different types of tablets that you can use that create secretions into the bowel or increase the motility of the bowel. And that's a summary of different types of laxatives. So they take home, some are not safe to use long term. You should consult your doctor.
All right, good.
So that's your constipation in a nutshell.
Great. Thank you, Dr. SAW. Viewers, thank you so much. I hope that this information goes a far way for you and your loved ones, your family, friends. Share it with everybody so that and if you know somebody who's suffering from this condition, this information is perfect for them also. Please ensure that you join us in the next segment just after this one, where we're going to be answering your questions from last week. So again, viewers, thank you so much, and remember, continue to send in your questions. See you on the in just a few on. Hey, viewers, welcome back, and this is the segment on the show of Ask Dr. SAW, where we answer your questions you would have asked last week. So, Dr. SAW, we got quite a few questions this evening, and last week we were dealing with acid reflux and heartburn. So most of those questions are related to that. So the first question here is, Doc, can skipping meals cause acid?
The answer to that is yes. So it is well established. Studies have shown that if you have infrequent meals, you can have increased acidity or reflux symptoms. And of course, it can give rise to heartburn. The exact pathology, it is linked to decreased sphincter tone. So I explained that the end of the esophagus, the beginning of the stomach, there's a sphincter there that tightens. And so infrequent or lack of meal can cause that tone to decrease, and you have reflux symptoms. But also, what tends to happen with patients who skip meals, generally, what they do, they skip meals, and then they go and eat a big meal.
Oh, right.
And it is also shown that if you eat big meals, you increase stomach pressure, and that can cause reflux symptoms. So it's a twofold thing that, yes, there's one thing that you're skipping your meal. Also, the acid is in your stomach, and there's no food for hours and hours. I mean, starvation. When we have and starvation, we tend to give them anti-acid medication. We're talking about, let's say, for instance, head injury patients or patients who are not getting anything in their stomach for weeks and so, because we don't want that acid. So there's nothing for that acid to work on. It can give rise to more ulcers and stomach problem, gastritis, and a bit of reflux will cause, of course, esophagitis and burning of the lining of the stomach. So yeah, I would say to that of course we don't want to skip meals. We want to eat, as we ought to. And yeah.
All right, cool. I want to share this with you quickly, Doc. I don't know. Well, you know this, and quite a few persons know this. That I eat one meal a day, and I drink a lot of water during the day. I know me and you are always at head with that sometimes. But I've finished 1 year since I've been doing 1 year, one meal a day. 1 year has finished. I'm into my second year. And I thought that I would have added something else. But the funny thing is, Doc, I don't know. I don't suffer from acid reflux. I don't have heartburn. I don't have any of these things. Is it then that my metabolism and my body has grown accustomed to this caloric intake at a specific time, and then what happens there?
I would imagine so, that our body, as living beings, one of the greatest things for us is adaptability. Mm-hmm. And that's one of the characteristics of living creature, of human being and mammals and maybe animals generally. Now, your body has adapted in a way, so maybe during the time of starvation, you are conserving energy. And then when you eat, you're expending energy. So your body has gotten accustomed to that. I would not at all, given the medical evidence we've got, to say that one meal is advisable.
No.
And I am sure you are doing this, you would only be able to do this for a period of time.
That's right, exactly, yeah.
Yes, you've got a purpose. You're doing this because, okay, I want to do, something different, or whatever the reason, or I want to lose some weight for a period of time, or I want to, whatever. So the point is, more or less, when we do things, we want it to be sustainable, we want it to be healthy, and we want to see that the evidence that if 100 people do the same, it must give us a net positivity.
Right.
Now, there are times when you have extreme outliers. So 100 of us can do something, and 99 of us have got positive results, and one of us might have a bad result.
Absolutely.
So, our body adapts in ways.
Yeah. And the reason why I'm asking, Doc, is because I know there are people out there who do intermittent fasting. They won't eat until they will eat 2 meals. They have a meal until 10. So it is not. So that's why I want to bring that up. I mean, mine is a bit extreme to say that I'm doing it as one. I haven't had that, but I don't want also for people who are doing intermittent fasting to be scared or to be frightened into going back to breakfast or anything like that. If you're managing it well,
correct.
Yeah.
If your body is adapted to that, and you're, remember part of EFI, the famous experiment by Pavlov, when they say they ring the bell and the dog salivates.
Right. Yes.
In school, we have that teaching, that if the mind starts thinking about food, what happens? The stomach starts to salivate.
That's right.
Yeah. Gastric juices.
Right.
So in preparation for food.
Right.
So if my body is inclined to get food at 8 o'clock in the morning, and I wake up in the morning and I say, hey, food is ready, I need food, I start mentally preparing my stomach by secreting digestive enzymes and acid to digest the food that I'm going to consume now.
You just answered my question. You just answered my thing there, yes.
Yeah. So if I'm psychologically prepared that, hey, you know what? There's no food here. Mm-hmm. I'm not going to salivate and start thinking that there's food and get the stomach prepared. So that's a very important concept. We have seen that from the basic of science that we have learned in school. And it taught us that you can condition the mind, body. And that was an experiment done.
Right. I followed the yogic. I followed a lot of the yogic principles, and this is one of the things. So the next question I want to ask here, Doc. Doc, can acid reflux lead to ulcerated stomach?
there's some, okay, so acid reflux leading to ulcerative stomach, ideally, I mean, I would say not quite true, but let me just explain that why. So we're talking about the stomach, we're talking about reflux is going up into the esophagus. So the esophagus, you have the stomach at the bottom. So you're having reflux, it's going into the esophagus. So if the acid is going into the esophagus, it's burning the
lining there.
So the question is a little bit tricky in that they're asking clearly, does the reflux cause stomach ulcer in the stomach? No, it will cause ulcer in the esophagus or inflammation in the esophagus. But the symptoms of reflux, like heartburn, can be as a result of ulcer in the stomach. So you can have ulcer in the stomach that give you heartburn, which can be interpreted, okay, that is reflux, but it is not reflux, it's a peptic ulcer disease. So you have ulcer in the stomach where ulceration of the stomach is caused by the acid penetrating the barrier, the normal mucosal barrier. So our stomach has got walls and thickness and there's a lining, so the acid doesn't eat into the wall of the stomach. If that defense mechanism is gone, then you have ulcers formation. And of course, also there is an infection. We talk Helicobacter pylori.
Right.
So if you have H. pylori, your barrier lining is compromised, then of course you have an increased formation of ulcers in the stomach. But the reflux itself is when the acid reflux upwards. So it is not, they are connected, so that reflux patients can have high acidity that can have stomach ulcer. So you can have stomach ulcer and reflux symptoms at the same time. But if you're asking me that if this acid reflux up into the stomach, into the esophagus, does that give you the ulcer? Well, that doesn't give you the stomach ulcer, but it can give you the ulcer higher up into the esophagus.
Okay, wonderful. Next question here is, what are your thoughts about stomach hernia?
All right, yeah, so that is one of the causes of heartburn. So when we talk about heartburn, remember I mentioned that heartburn can be as a result, as a matter of fact, reflux is probably the most common cause of heartburn, and then you have acid, you have peptic ulcer disease where ulcers cause heartburn. Now, hernia, as we know, what is a hernia? So the hernia, the parts of our body are in, different compartments, and they have a lining covering it. And if something bulges out into that lining, pushes out, it's called a hernia. Or if there's an opening, so let's say there's an opening and something is coming through, that is called a hernia. So in your bowel, in your umbilicus, there's an opening there. If something bulging through your umbilicus, your navel, you could say that's umbilical hernia. In your groin, if the abdominal wall, the lining is weak, the bowel pushes out. That's called a hernia. But there's a special type of hernia in the stomach. I said earlier that the esophagus pierces the diaphragm. So the diaphragm is the separation between the chest and the abdomen. You have a diaphragm. So this esophagus, the gullet, goes through that, and then it enters the stomach. Now, there are times when there's a weakness in that area, and it causes the stomach to push up into the opening.
Oh.
So the stomach rides up into the chest. Now, that is called a hiatus hernia. And because it changes the anatomy of the sphincter, it can cause weakening of the sphincter, and you have acid coming out. So hiatus hernia is a well-established cause of reflux and is a well-established cause of heartburn or symptoms of heartburn. So, and yes, again, small hernias, you're probably not going to do anything about it. We'd advise also if your tummy, if you've got big abdomen, there's lots of pressure in your abdomen, it causes more, weakness, and it pushes up higher. It makes your hiatus hernia worse. So always we will ask patients to do some lifestyle modification. You lose some weight, you don't eat big meals one time, they go and do a surgery where they, tighten that weakness.
Okay. All right, Doc. The next one here is, what are some natural remedies to prevent acid reflux?
Yeah, well, those are the natural remedies I was alluding to just now. So, of course, we talk about lifestyle. So, nothing with medication, simple lifestyle. You want to eat regularly. You want to eat smaller meals and bigger meal at one time. You don't want to eat within 3 hours of going to bed. You can elevate the head of the bed a little.
Right.
So you don't have reflux symptoms. Your type of food that you're eating, you want to cut down on your spicy, your oily, your acidic food, tomatoes and citrus. You want to cut down on that. Your tea and your coffee. You want chocolate, tea, coffee. You want alcohol, cut down on your alcohol. You want to exercise regularly. You want to, what else? I mean, stop smoking, because smoking also diminish the sphincter tone.
And what should we add to the diet more? What should we add to the diet more?
Well, you want the healthy fruits and vegetables. You don't want so much of processed food.
Right.
So it's about eliminating the kind of fatty processed food and have more wholesome, whole grain, and healthy diet.
Wonderful.
So I think that's
excellent.
Next changes.
Thank you. Next one here is, what causes one to burp all the time, especially at night?
All right. So that's lots of reasons. The bloating. We know our body has got the bowel is probably the highest concentration of bacteria, and the food we eat, we can swallow gas while we're eating, so we have gas into our stomach. The bacteria that lives in our bowel produce gas, and that also can cause formation of gas and can cause us to belch or barf.
Right.
Now, you can have other causes where your stomach bloating from your food. The type of food you eat is important as well, because the bacteria ferment. They are a type of fiber, which some fermentable, non-fermentable, and different bacteria. So the new concept of the microbiome or microbiota, have you heard of that? So that is your intestinal bacteria, can cause gas. Now, if someone is telling me that they're bloating or they're belching a lot of lots and lots of gas, I would want to, of course, establish, do you have any heartburn symptoms? So is this due to reflux? So if you have weakened sphincter, you would have, more reflux or gas coming up or acid coming up. I would want to make sure you don't have gallbladder disease. I talked about that before, that if your digestive tract, your gallbladder produce bile. If you have pancreatic problems, you produce bile. I would also want bloating also as a cause. If you have another abdominal pathology, you have a mass in your stomach. So patients who have got fibroid, patients who have got ovarian cancer, who have got a tumor in the abdomen, they feel bloated. And if you feel bloated, that can also put pressure in the stomach and it pushes up the gas. So those things. But a common condition, and which when we investigate patients for bloating and we find, okay, fine, there is nothing sinister, nothing dangerous, there is something called SIBO. It's small intestinal bacterial overgrowth. Okay. Small intestinal bacterial overgrowth. So another cause of bloating would be Helicobacter pylori. So if you've got Helicobacter as an infection, can cause bloating. But in your small intestinal bacterial overgrowth, that is bacteria in your intestine producing too much gas. So if I've got a patient, we can test for that, a breath test. Also, empirically, I can treat. So if I've got a patient with lots of belching, lots of bloating, and I've investigated them and I can't find anything specific, sometimes I give them a course of antibiotics.
Oh, okay.
And there's a regime specially for SIBO.
Mm-hmm.
So it's called SIBO. So there are special type of antibiotics you use that stays in intestine longer, kills bacteria, and
Right.
So yeah, these are the causes.
Good. Doc, I got 2 more questions, but viewers, I just want to remind you, continue to send in your questions. It doesn't have to be about tonight's topic. Anything that's bothering you, sending it in, and as long as Dr. Saw is capable of answering those questions, next week we are going to be dealing with it. So continue to send in your questions. We got 2 more questions to go, and the next one is, Doc, hi, when I wake up, my mouth has a funny taste.
Right.
I've had that too. You get a bitter taste in your mouth, right?
That tells me reflux.
Okay.
So there is something called water brush, where you wake up and there's lots of saliva in your mouth.
Mm-hmm.
So that's also a sign, a symptom of reflux. That funny taste in your mouth is stomach acid coming up, you regurgitating.
Mm-hmm.
So that's a classic symptom of reflux. Bile, that funny taste can come from bile acid. So I said to you that gallstones, gallbladder disease, biliary obstruction, pancreas problem that, for instance, if you have a tumor of pancreas, it blocks the flow of bile, and you can have all those symptoms. But the common things are common, and I'm giving you,
right.
all the possibilities. And of course, my job as a doctor generally, I always say to patients, my job is to think the worst, exclude the worst, and hope for the best. I hope it's the best case scenario. So I always discuss with you, okay, you've got a symptom, and it could be A, B, or C, or D, but common things are common. These are common things, and probably, let's hope that's the best case scenario. And the rare things, they're dangerous, and of course, I have to exclude them before I say, hey, you're good to go. When I say you're good to go, you're good to go.
Yeah, right. I like that. Last question here, Doc. Can you take yourself off metformin if you keep your let me go back again. Can you take yourself off metformin if you keep your glucose levels under control?
Yeah, of course. I mean, I would say yes, you can. There's always that feeling that if we start a medication, I have to take it for life. And that is true most of the times for chronic conditions. So if you have high blood pressure, you take your medication. So patients always come to me, they take their medication and say, okay, doc, my blood pressure is good now. Can I stop the tablet?
Yeah.
I say it's only good because you're taking the tablet.
Right.
And likewise, if you have diabetes, but it doesn't mean that the tablet, you're hooked on it, that you can't stop it. So there are 2 components to that some people feel that I'm taking something, and if I stop, my body is at a loss and I will collapse.
Right.
Now that is true for certain drugs like steroids and psychiatric drugs. Generally, you have to wean yourself off gradually. But when it comes to blood pressure tablet, if you miss a dose, you're not going to feel any way different, except your blood pressure might go up. And depending on how high is high, you would feel symptoms if that's the case. But metformin, so the question really is about, my sugar is back to normal, can I stop the metformin? In most cases, no. There's no need for you to stop it because it is only good because you are on the drug.
Right.
You understand? Your
Yes.
sugar is controlled. Because why are you going to stop it? My sugar is high and I'm taking metformin. And I test my sugar again and my sugar is normal. It is because the metformin is doing that. It is controlling my sugar. However, there's a caveat to that if I feel that I have done something different, I have done a lifestyle modification, I've lost weight, I've changed my diet, I have been exercising, then I can say to you, hey, maybe we can stop metformin and see what happens. Mm-hmm. So let us take a break for a month, let us test your sugar again, and if your sugar continue to be normal, then maybe you can stop it. So the answer to that is yes, you can stop it. However, don't prematurely stop it thinking that, oh, I'm okay now, so I can stop it. No. If you have done an intervention, a lifestyle intervention that goes with it, and that lifestyle is actually the reason for the sugar to get better, then of course you can stop it. But I want to make a point here on the metformin especially. I give metformin to patients who don't have diabetes.
Mm.
So there are a set of patients, women with something called polycystic ovaries.
Right.
They have insulin resistance, they're overweight, and they have irregular periods. And I will give them metformin. they don't have diabetes. Because how metformin works, it allows increased sensitivity to insulin. So metformin is now one of the drugs that if you take it, your sugar will just dip and you will feel lost. No, it doesn't do that. It allows your body to use the insulin that is already there. Your body is producing that insulin anyhow, and it allows the body to use it better. So at times, you can take metformin without having diabetes. And secondly, there are lots of patients, before you have diabetes, you have something called pre-diabetes or borderline diabetes. And sometimes I prescribe metformin to these borderline patients, especially if you're overweight, you're pre-diabetic. I would say, okay, let us start you on metformin because you have more to gain than to lose because you're high insulin resistance.
All right. Well,
so these are the kind of things.
Well, thank you so much, Doc. You know, it's a big weekend here in Guyana. It's all over the world. It's Easter here. It's Easter weekend. Friday is Good Friday, and then Easter Monday. Usually, the weekend here in Guyana, there's be a hype of activities. 63 Beach. I think you're from Doc. You're from Berbice. Yeah. As a young, before we close, I want to ask you, viewers, and you can tune in here too. Before you, were you one of the kids who would use the pace kettle, gamma cherry, and
Oh, absolutely.
Yeah, man.
That's the rite of passage.
Yes, I did that too. I used to make star
I
pint.
mean, I used to make my own kites. My brother and I, we used to make kites, and it's a fun thing.
All right.
And then going to 63 Beach was a big thing in Barbados. Easter Monday, 63 Beach is the hot spot.
Well, this weekend got a wedding starting. My neighbor has a wedding this weekend. The people who live opposite me got a wedding starting Friday. I think it end next week Friday. So let's see if I can make it for the show next week, Doc. But to all our viewers, happy Easter to you, and a good Friday. Enjoy your Good Friday. Remember the reason for the season, and remember to stay healthy, stay strong. Anything from you in closing, Doc?
Again, thank you and the team, and to the viewers, and thanks for tuning in. And I want to wish everyone happy Easter. Have a good Easter weekend. I know it's a season, really. Yes, have fun.
All right. Have some good fun and stay safe, and just be responsible with everything that you do. We will see you next week, Tuesday. Stay safe and stay healthy.